Typically, when a patient presents with esophageal or GE junction cancers, we usually have already an endoscopy and biopsy to make the diagnosis. At the time of the endoscopy, you localize the tumor, so we identify whether the tumor is in the esophagus or GE junction or more distally in the stomach. And we generally consider esophagus and GE junction extending up until about 2 centimeters into the gastric cardia. We can subtype GE junction tumors, Siewert 1, 2, and 3. Siewert 1 and 2, mainly esophagus GE junction. Siewert 3 tumors are cardiac cancers with some GE junction that are classified with gastric cancer. So in terms of Lauren classification, that's really more an issue for gastric cancer. We're actually moving away from that now because we have more molecular-based characterization. But for distal gastric cancers, we have intestinal cancers, which are the more traditional adenocarcinomas, the association with Helicobacter pylori infection. The Lauren diffuse cancers are more poorly differentiated. They usually don't form a mass. They're usually not associated with an ulcer, and they're more limited in the gastric wall. That being said, they're really treated the same way, both in metastatic disease and the surgical and adjuvant setting. We typically do endoscopic ultrasound to identify the T and N stage. We always start with a CAT scan to rule out distant metastatic disease, and if patients have local regional disease, no evidence of metastatic disease, we usually do an endoscopic ultrasound to identify T and nodal staging. For gastric cancer, that's relevant because if the tumor is T3 or node positive, we also do staging laparoscopy because about 20% of patients will have peritoneal metastasis. We don't do that so much for esophagus and GE junction because the yield is less than 5%. So, I mean, for molecular subtyping, that's not so relevant for locally advanced disease. That's not going to impact on your treatment decisions at this juncture, but we do see that there are 4 major subtypes of esophagogastric cancer. For esophagus and GE junction cancers, 95% of these cancers are what we call genomically unstable, and that also represents about 50% of gastric cancer. So there's clear analogy between esophagus and GE junction cancers and about 50% of intestinal gastric cancers. They share similar molecular profile, which is the tumors are dominated by P53 mutation and amplification of receptor-associated tyrosine kinases, the most important of which is HER2, and also EGFR, FGF, and MET. The other subtypes are all less common and more seen in the distal stomach, and those would include genomically stable tumors, which accounts for the large proportion of diffuse cancers. Those are genomically relatively bland. We don't really see a lot of mutations, and we see often CDH1 somatic mutations and RO1 mutations, which are not targetable. Then 2 very small other subsets, MSI high distal gastric cancer, which is usually arises from hypermethylation promoters, and of course one of the most important promoters is that the silencing of the promoter that results in diminution of DNA mismatch repair proteins. You get rid of those proteins and you get high mutation burden. So MSI high, in the TCGA analysis, they reported about 20% were MSI high. In reality, in the US, it's probably 10% or less, and in metastatic disease, probably only about 5%. And then lastly, Epstein-Barr virus-associated cancers, which accounts for about 5 to 10%. So the common subtype would be the genomically unstable, which is almost all the esophagus and GE junction tumors, 50% of gastric cancer, and then a smattering of these other subtypes. And again, that being said, that does not impact on your decision in terms of locally advanced disease. And right now it still has limited impact on metastatic disease. We'll talk about the role of MSI and HER2 in a little bit.